we still, I'm still doing open, So
I'm sure you will start soon.
yeah, yeah. Let's hope so. So how is your liver transplant program going on?
Liver transplant program is hoping to be launched.
See,
Yeah, Sandeep, you start now. It's 8 o'clock.
okay.
You
Just
start.
just
What will happen, Sandeep? You introduce the speaker,
yeah,
speaker,
yeah. I'll just do.
and the
I'll
panel,
tell.
and
I'll
at
tell.
the end, just give. I think the J&J guys has got some slides to show.
Yes, yes.
Just give them about 5 minutes. Okay.
Yeah. Okay,
Yeah,
okay,
crack
okay.
on.
Well,
You crack on.
so
Yeah.
I'll just give an introduction, the historical background. As you know, the Karl Langenbach did the first liver resection successfully in 1888. So and the sectioned liver came out to be non-disease. There was no disease. That was the beginning of liver section. And as 1950s, there were no liver resections done successfully because people didn't have any clue about the anatomy and the functional anatomy or the surgical anatomy until 1982, when the Henry Bismuth actually published the anatomy, the surgical anatomy, anatomical surgery of the liver. And then actually it provoked a lot of hepatobiliary surgeons to come forward. And obviously, with the introduction of intraoperative ultrasound, which has definitely gave the plan, the map, the roadmap for the liver resections to be done safely. So, with this introduction, I think, uh, bearing in mind the HCC, the liver resections poses about 60% of 5 year survival, and nonetheless the colorectal metastasis, it's above 40 to 50% 5 year survival. So with this sort of utility for liver resections, we go ahead with today's program with the main speaker, Dr. Subhas Gupta, who is the founder chairman of Max um, Center of Liver Disease, who is a pioneer of living donor liver transplantation in India, and he conducts about 300, more than 300 liver transplantation in every year, apart from the hepatobiliary, benign hepatobiliary disease. And he's trained in QE Birmingham and Leeds, and later acquired training in South Korea and Japan. And he's is proud to be announcing that he's the BC Roy National Award winner for developing liver transplantation in India. So over to you, Subhash. You carry on with your presentation.
Thank you very much for those kind words of introduction. And yeah, and I feel very strongly bonded whenever I have to do something for Calcutta, because many of you will probably know I come from a small town called Asansol, where I spent all my life and ended up accidentally being in Delhi. Never planned to be. In fact, I'd gone and applied for a job in Kolkata, but they said that I'm not not a general surgeon, so I cannot get that job, because that time I trained the GI Dr. Nandi. So what I've done is I've left the laparoscopic bits to Dr. Shaleen, and I'll talk about open liver resection. And liver resection is required for a variety of disorders, for benign conditions, for malignant conditions. And one area where all surgeons should be familiar with liver resection techniques are hepatic trauma, because everyone in their career will have one or two exposure of a person with blunt trauma, or even penetrating wound of the liver. And if they're familiar with the techniques, they can save these patients. So it's always a hot topic for surgeons, liver resection, because it's a highly vascular organ. There are coagulation disorders, there's portal hypertension, exposure is difficult, and there may be incomplete mobilization, or right lobe mobilization is particularly difficult. Now, one thing that this is something that I like to say in the beginning, that we often worry about the INR values in cirrhotics, and believe me, the INR values do not reflect at all the bleeding tendency of the patient, and loss of anticoagulants is matched with loss of procoagulants, and there's a balanced hemostasis. In fact, in some conditions, the liver disease may actually make them more thrombogenic. And over the years, and most people all over the world will agree that operative impression has far more reliability than any test result. And a close interaction with anesthetist is important for decreasing blood loss. And real-time tests for coagulation, such as TEG, may give far more information than INR values or even platelet values. So what I'm not going to discuss, which is another section, which is diagnosis, assessment of liver function, calculation of functional remnant liver volume. Also, we'll not discuss maneuvers for augmenting remnant liver volume, but focus mainly on techniques. So safe liver resection, one of the prime conditions for safe liver resection is avoiding blood loss. And if you have blood loss, then you have increased post-operative morbidity and mortality, and also will decrease long-term outcome. So some of the methods that we use for minimizing blood loss are low central venous pressure, vascular occlusion techniques, anterior versus posterior approach, anatomic and segmental dissections, use of parenchymal transection devices, and post-transaction hemostatic procedures. So we don't have to repeat to this august gathering that low central venous pressure is instrumental in decreasing blood loss. However, there is theoretically a risk of venous embolism, and that can be decreased by placing the patient in 15% Trendelenburg position, 15 degrees position. Now, if it's a long and difficult transaction, then it must be smooth, multiple senior surgeons, regular breaks, prevent clamp slippage, and raise CVP after transaction. This is something that has not been highlighted enough, but lower CVP is good for transaction, but once transaction is over, CPV must be raised so that the clips and ligatures and the IVC do not slip. Intraoperative ultrasound has become a sort of important adjunct to liver resection, and all hepatobiliary surgeons must become familiar with intraoperative ultrasound. There is, of course, a territorial dispute with the radiologists because they think we are going to take over their area, but nevertheless, we can still work jointly with them. We can call them, but we need to learn the techniques of intraoperative ultrasound ourselves. Interestingly, the availability of CT angiogram has decreased the dependence on so much on exploration. That means the CT angiograms nowadays are fairly accurate. In fact, CTs and MRs will probably pick up more than the ultrasound can pick up. And the growth of living donor liver transplantation in India has allowed for greater understanding of liver vascular anatomy. And one of the key things that all liver surgeons must learn is how to identify the middle hepatic vein while they're transecting. This you could do with an ultrasound, but sooner or later you can learn to do it by using the transection device that you're familiar with, and you can move the MHV either to the side you want to remove or either you want to preserve. And this is an important learning point. In fact, in Japan, they say, and we had a fellow from Japan who spent a year with us, and he said that if you cannot identify the middle hepatic vein during transection, then you're not a liver surgeon. So hepatic venules are thinner, bluer, and relatively larger as compared to portal vesicles. And so because they're put a clip or a tie on it rather than you should slow the transection at that stage. And by tying and ligating these venules, you can move the MHV to the side that you want, and the Cuser settings, if that's what you use, can be lowered to prevent bleeding. So this is something that we instrumental in developing this technique, which is we call the clamp test. And you can see this is a picture taken from a donor operation. You see the ischemic lines has been marked, and you can see that the area drained by the middle hepatic vein is nicely demarcated here. So this is also the anterior sector of the liver, and so you want planning a segmental resection. You can use this information to know where is segment 8 and segment 5. Now, coming to vascular control, there's a methods of extrahepatic vascular control where you portal vein, hepatic artery, and common bile duct are followed up to the divisions, appropriate site dissected and divided. And this is the classical approach used in living donor liver transplantation, and hepatic veins are dissected outside the liver. But this is not so important for when you're doing dissection for HCC or for colorectal conditions. So there are different approaches to there's an anterior intrahepatic approach and the posterior intrahepatic or Glisonian sheath approach. And I've got a nice video to show you how you can get the pedicles of different segments by the Glisonian approach, and that's later on. Now, there are pros and cons of vascular control. Some surgeons will say that you mobilize the liver to be resected, you transect it, and then get control. In that way, there is no risk of erroneous ligation, and risk of bleeding can be eliminated by careful transection techniques, which tends to be slower, but still can be done. So this is one example where the middle hepatic vein has been sort of identified within the liver. And in this particular case, it is lying with the side that we want to remove. This is the right lobe. And here it has been slung, and then can put a stapler and divide it. So there can be different types of vascular control maneuvers. One is inflow occlusion, of which there's total inflow occlusion, or there is selective inflow occlusion. Selective meaning that you occlude only the area that you want to remove. And then you can have both inflow and outflow occlusion, where you can have total hepatic vascular exclusion, you have hemihepatic vascular occlusion, or you have total vascular exclusion with preservation of caval flow. I'll show you some pictures of that. So by and large, the Pringle maneuver is very important. In fact, everyone is familiar with Pringle maneuver, which is en masse clamping of the portal structures. And increasingly now, I find that the laparoscopic surgeons are using this much more than we did before. And also many of the living donor liver transplants that are being done laparoscopically, many laparoscopic surgeons say that it's safe to do an inflow occlusion, complete inflow occlusion without damage to the graft. But it's something that when you're doing with cirrhotic resection, we are not comfortable doing this. So there were trials to look at what happens to blood loss. And if you use the Pringle maneuver, the blood loss is obviously less, and the transaction time is even less. So what about continuous or intermittent clamping? You can do continuous clamping up to 60 minutes, or you can do intermittent clamping. But by and large, we don't like doing this when we are doing a cirrhotic resection, and I'll show you some videos of that. The selective vascular occlusion is more popular. It limits the ischemia of the side of the liver to be resected. And I said earlier, it's important in cirrhotic patients. There's less stasis and venous hypertension in mesentery and bowel, and first described by Bismuth and Makuchi. And this resulted in significantly reducing blood loss. So this is where those of you can see it here. You can see the hepatic artery, right hepatic artery is dividing into an anterior branch and posterior branch, and portal vein, posterior portal vein branch. And you can see there's a line on the posterior surface, and this will give you if you want to resect the posterior sector, you can use these guidelines. And the transaction proceeds just to the right of the anterior hepatic artery. Now, total hepatic vascular occlusion, sometimes, generally not something that I would advise anyone to do, but occasionally you will have to do it. And I'll show you one such case where we had to use this recently. And the suprahepatic, infrahepatic, and everything is occluded. Occasionally, if you have access to veno bypass, you can use it. But generally, nowadays, most liver surgeons have stopped, including transplant surgeons, have stopped using veno-venous bypass. So this is total hepatic vascular occlusion, with top is clamped, bottom clamped, inflow is clamped, and the patient needs to be volume overloaded, and you test with trial clamping of 5 minutes. And this is major changes in hemodynamics, and the liver anesthetist must be able to cope with these hemodynamic changes. So Belghiti did this first study on hepatic vascular occlusion and compared total vascular occlusion and continuous Pringle maneuver. And they found that there was no significant difference in ischemia time of blood loss in routine cases. But however, when there were large deep-seated tumors or tumors abutting hepatic vein and IVC, or there were hypervascular lesions, this was of help. An important technique that surgeons should be familiar with is infrahepatic cable technique. Sometimes you do not have a very cooperative anesthetist and the CVP may not come down. So in this particular situation, if you were to just clamp the lower cava and do an inflow occlusion as well, you can have almost a bloodless liver resection. And this is something that occasionally you may need to do, which is that you keep the cava going so that there's no major hemodynamic changes. And this is particularly important when you're doing resection in non-cirrhotic patients. Because non-cirrhotic patients do not have portacable collaterals, and they tend to have, if you clamp their cava, you clamp the portal vein, then they will have a major hemodynamic change. But this is another technique that can be used where you selectively loop the right vein, left and middle vein junction, and the IVC and the cava keeps flowing. Now, or if you have a tumor which is in segment 8 and close to the veins, then you can do where you clamp the lower cava, you clamp the right vein and the cava, and then you can sort of resect the side which has the tumor in it. This is called isolated total cable clamping. And this we had to use in a patient who had a tumor this big, which was on segment 8, going into the IVC. We clamped the lower end, and then we were able to resect this lesion without major hemodynamic compromise. So the vascular control measures is 90% of the time is possible without vascular control. And living donor liver transplant, classical example is without vascular control, because there have been technical advances such as CUSA, argon beam coagulator, low CVB anesthesia, and improved understanding of segmental anatomy of the liver. I think I've lost connection there.
Hello?
I think I stopped. I don't know what happened here. Okay. Now, one of the things that can trouble a liver surgeon, particularly if you're doing a right hepatectomy, is if you are ligating clamp slippage, particularly if the anesthetists are giving bolus muscle relaxants rather than a continuous infusion. So if the phrenic veins must be taken from, and so that the vein can be separated from the diaphragmatic fibers, and then once you've done that, then you can clamp the vein, right hepatic vein safely. Now, I want you to look at this video carefully. Let me see whether the video plays. Yeah. So this is a very important video in which what you can see is where you can get the Glisonian approach, where after you've done the cholecystectomy, you'll find gaps between different pedicles, and you can enter these pedicles selectively, and you can there are anchors that you need to take down, and the gaps between the anterior pedicle, posterior pedicle, and here we're trying to get into the anterior pedicle, and if you do that, then you can demarcate the anterior segment, and further by work on this area, you can actually identify the G5, G8, and the different branches. And this gives you, particularly in cirrhotic resections, gives you selective inflow occlusion, and you can do this with, it takes a little practice. And here it tells you how you can get into the posterior pedicle. So you freed the area, what we call, the Japanese call the gate theory, and you can resect this, and you can have posterior sector demarcated. Now, once you've done that, then you can, you can also use this to do caudate lobe resections by getting into, by getting the pedicles extrahepatically. This is a resection in cirrhotic. So once you've taken the ranchius plate, you can get into, you can get into to the left of the pedicle, and I'll show you some slides of this, how we did it in a case where we needed a segment 3 resection, and you can then this is the entire left lobe pedicle can be approached extrahepatically, and then by serial dissecting on it further, you can get the different pedicle even to the caudate lobe, and this is isolated for segment 4 pedicle, and that can be, so this sort of anatomy, this whole thing can be loaded. This happens because the Linax capsule and the Glisonial capsule, there are some gaps in between, and this is one where it will show you how you can do a complete caudate resection by taking the paracaval pedicle and pedicle on the left side, and the entire inflow to the caudate lobe can be taken. Now, this I'll show you a classical resection in a 73-year-old gentleman, cirrhotic, who's diabetic. There's segment 3 HCC, classical enhancement and washout on MR, and we had to do a mono-segment resection because it was completely cirrhotic. So this is what it was left. We took out segment 3, and this is what it was left. You can see the segment 2 pedicle here, and this is what the liver looked like after we were quite ischemic, and in fact the patient recovered without in 5 days time. And this was the tumor that we took out, multifocal HCC, but only limited to segment 3. And this is, you can see that we did a cholangiogram through segment 3 duct by putting a tube, and you can see the entire segment 2 duct and everything visible nicely. And this is the post-operative picture of MR scan, and you can see the segment 2 pedicle is intact. So these are the advantage of segmental resections and cirrhotics. And So this is how you would do a segmental resection, by getting the inflow extrahepatically. Now, for large bulky tumors, you need to do what we call the anterior approach, and so you do the ligation of the inflow vessels, and then you don't need to divide them at this stage, because if you divide them, then you lose their sort of you can cause a Wallstone injury. So you just tie them, leave it there, and then you pass finger from above and below to open the space in front of the cava. A tape will pull the liver forward and allow for easy transection. And this is what we did recently for someone who was 81 years old, is a brigadier, and the liver, they're not frankly cirrhotic, but early cirrhosis there. And again, he recovered nicely. And that brings me to the end of a talk, and we show how we recently celebrated 3,000 liver transplants in our center. Thank you for your attention. And perhaps I can answer the questions now, or once Dr. Shalin's talking.
Now, Subha's wonderful presentation. I think the panelists are allowed to ask questions directly to Subhash now. And when we finish half an hour mark, then we will let Shalin to present his talk.
Okay.
So,
Hello, sir. Thank you for the excellent presentation as usual, and some amazing images as well. Although I'm sure that many of us lost you when you were discussing the complexity of the gate theory of the Japanese. I think that was a little complex for some of us. But the question that I would ask you is, any suggestions, any tips and tricks for pure caudate lobe tumors?
Yeah, there are two approaches for caudate lobes. One is that I showed you with the that you can do it by the taking the pedicles extrahepatically. Or what more classically we sort of transplant surgeons are trained is that you mobilize the from the left, take it off the cava, and then you tie the tributaries, and then resect it. But this will not sometimes. We did this one for a cirrhotic patient where we took out the entire caudate lobe with the margins. So you have to mobilize from the left, take the caudate lobe of the cava by tying the short hepatic veins, and then and also the caudate lobe branch, and then it twists to the right, and the entire caudate lobe can then be removed. But what I showed you is perhaps something that needs more attention. There are branches both from the right and the left, and those pedicles can be tied, and you can take out. And that what that does is that it lifts the sort of portal structures higher up, and then you can remove the caudate lobe from below.
And one more question. We have never, but any experience with post-transplant liver resection ever?
We could do it because we do a lot of retransplants, but many of them that we find that needs resection, our interventional radiologist is able to do either an RFA or microwave. In fact, there's a patient from Calcutta who we transplanted 4 years ago, and then he had a recurrence in the liver, and he's still alive now. And we did a RFA for that liver lesion. Of course, he had some pus formation at the RFA entry site, but he's now completely resection free, recurrence free.
Would you be open-minded to liver resection at all, or always RFA?
We could do it, but now with the sort of radio RFA and microwave, I think
manageable that way.
These guys do a much better job. But obviously, if they fail, we could do it, because strangely the mobilization in post-transplant is actually not bad. You just have to be a little patient, and you are able to mobilize. Because related topic to this is that in the beginning we were very scared of doing hepatico-jejunostomy post-transplant, but now we will do it, because it's so much easier than having a gastroenterologist first putting a pancreatic stent and then missing one duct, second duct. So routinely we would now actually do a hepatic. So it's not that difficult post-transplant, because strangely the planes are as intact as before.
Thank you.
Subhash, one question.
Yeah, you carry on.
One question. Any experience of resecting IVC wall or doing ex vivo for infiltrating tumors into the IVC?
We have had experience of that, but those cases for leiomyosarcoma of the IVC, we've removed in the past and put in a sort of a graft to do that. But it requires a lot of patience, and you need to mobilize the liver fully from right side. And sometimes, of course, we've also sort of done this in with a graft ready, so that just in case there's some problem, we can implant the liver again. But I think the indications for what I think you're asking about is ex situ resection. Is that what you're asking?
Yeah,
Is it?
that's
I
you're
think
right.
the indications are not that many, and it's something that's often worries me, because so we'll try and remove it in situ rather than ex situ, because sometimes when you reperfuse and rejoin, things may not be that good.
Two questions, Subhash, basic questions. One is about in the cirrhotic liver, when there's a tumor where you probably end up doing a non-anatomical resection. Do you prefer doing, or you don't prefer at all doing a non-anatomical
I
resection?
was very keen to do anatomic resection, because that's what the Japanese and everything. And we showed you we do a segmental resection of three. But I think our laparoscopic surgeons have come in and they say that there is no difference at all in survival whether they do anatomic or non-anatomic, because obviously
Yes.
anatomic resection in laparoscopy is very difficult. But I would still favor segmental anatomic resection, though the data does not show that there's any advantage as far as what has decreased the recurrence issue is that the imaging nowadays is excellent. So if you have someone whom you resected and you do every 3 months an MR, we prefer doing MR scans, because obviously can't expose them to so much radiation. So every 3 months they'll have an MR scan. We pick them up, and then our interventional person will sort of hit them with RFA or microwave. And we've done this on a number of occasions, and that
Right.
seems to be.
Now, the next question, short question is, for the parenchymal resection, what uh, energy source do you use? Do you use CUSA all the time, or hydrojet, or
I've used almost all the devices. I've used CUSA, I've used WaterJet, and I've used harmonic scalpel, and I've also used finger fracture. In fact, I had a video of that showing all the techniques, but I thought it'll be too long. It's sort of late in the evening. But I think the CUSA has advantages, big advantages. Now, this question has again come into recent discussion, because the many liver surgeons are going the robotic route, and the robotics say the surgeons that they have a difficulty because there is no robotic CUSA available as yet. So this question becomes important nowadays again. But with the CUSA, the main advantage I find with the CUSA, the machine is very robust, and the ones that we purchased years ago are still serving us well. Whereas with the WaterJet, which may be faster, but the accessory, the probe needs to be. I think it works only for. The company refuses. They will not allow you to use it for multiple patients, because some clots may stay inside, and you're doing the section for hepatitis B and C, and you can the company does not allow you to use it, and that's works out to about 50,000-60,000 rupees extra per case, whereas the CUSA can be there forever. But for as far as we've been sort of watching Dr. Shalin do a lot of laparoscopic work. So a lot of liver resection can now be done with harmonic scalpel. And when you get into once you've done a little bit and you want to expose the vein, then you use the CUSA. And in fact, I was speaking to Sudhindran, who's now does a lot of robotic surgery, and he said that does the harmonic, but the assistant with the robot, he's learned to use the CUSA, the ordinary CUSA with the robotic arm. So I think CUSA has a lot of benefit, but it's not something that you need. It's a
right?
must to do liver resection.
Right. Thank you very much, Subhash. I think we move on to Shalin now. Uh, um, uh, he is the director Max Hospital of Surgery, Super Specialty of Liver Transplant and HPB. He did the masters from BHU and MCH from SGPGI Lucknow. Transplantation Fellowship at New York, and his main interest is immunology for chronic liver disease and liver cancer. Please, Dr. Agarwal.
Thank you, Dr. Sandeep. Thank you for that kind introduction. And after having heard in detail from Dr. Gupta about the progress of liver resection and the open liver resection, various techniques, I would like to focus mainly on the developments that have occurred in the field of laparoscopic liver resection, and that has generated a lot of interest in the recent years. So, is my screen shared? Are my slides visible?
Yeah, visible, right.
Okay, thank you. So I'll be talking about laparoscopic liver resections, and I would be discussing under the following headings: a little background, then appraisal of advantages and disadvantages of laparoscopic liver resection. And then, since we have a lot of transplant experience, so I would be talking separately about laparoscopic living donor hepatectomies, share our initial experience of laparoscopic liver resections, and the salient features of our technique, and then I have a video of right donor hepatectomy, and then just a few lessons that we have learned over the course of our short experience with laparoscopic liver surgery. So the first laparoscopic liver wedge resection was reported about 28 years back in 1992. And during the last quarter century, there has been gradual but increased acceptance and application of laparoscopic liver surgery. And as with any new technique, you need to standardize the indications, to standardize the techniques, and two important international consensus meetings have therefore been held. These are the two most important ones. There are numerous other meetings that have been held, but these are the most commonly cited ones. And the first meeting was held at Louisville, USA in 2008, and that established the feasibility and safety of laparoscopic liver resection. That is, it is possible, it is safe for the patient, it's doable. Then the second meeting was held about 8 years later in Japan, because Japan made rapid progress and giant strides in the field of laparoscopic liver surgery. And in that meeting, there were a panel of experts, about 25 experts from all over the world. They compared laparoscopic liver resection with open liver surgery, and they established the adequacy of LLR, particularly with reference to resections for malignant disease, especially colorectal mets and HCCs, which are the main indications for laparoscopic liver resection in most of the centers doing this kind of surgery. And as I just said, there's been a gradual broadening of indications and spread of expertise to multiple centers in most of the countries around the world that are doing liver surgery. And this is a slide which pictorially, graphically represents that development, that how over the years from 1996 onwards, the number of publications for minor, major liver resections have grown. And the lower graph shows how the major liver resections, which are depicted in green, the numbers have grown as the experience and acceptance has grown. This is just a graphical representation of what I said. So just a slide about understanding what is laparoscopic liver resection. It's nothing different. The indications are more or less the same as for open resections. So laparoscopic resection is just a different approach. It is not a different surgery. It is a different approach to doing a liver resection. So indications remain the same. Preoperative assessment, postoperative management remain the same. Again, it's indicated for both benign and malignant lesions. However, what is different is that pre-op assessment of difficulty of laparoscopic liver resection, especially when you are in the initial part of your learning curve, is extremely important for the success or successful completion of the surgery laparoscopically. And what are these assessment parts? Basically, whether the patient is fit for a relatively longer surgery. And what is more important is the nature of the liver, that is whether it's cirrhotic or non-cirrhotic. In the early part of your experience, you would not like to straight away proceed with cirrhotic livers for resection. Tumor size is extremely important. Larger tumors run the risk of rupture. Location is important because this is actually most important point, because tumors located in the posterior segment, so the superior segment, segment 8, 7, are extremely difficult in the initial part of experience to approach laparoscopically, though it's a bit easier robotically, but location has to be considered. And then the proximity to vessels, because bleeding is the nemesis of laparoscopic surgery. It just ends your surgery and you are forced to convert many a times. What is the basic conceptual difference between the laparoscoping and the open approach is the vision. That is how you approach. When you are doing the open liver surgery, you are seeing from above. That is what we call the anterior approach. You are seeing the liver from the surface. While laparoscopically, you are seeing the liver from below. That is what is the caudal approach. So it is from below upwards, while in the open approach, it is from up to below. So that is the basic conceptual difference. It is the approach to the liver, the vision of the liver, whether you are seeing from above or below. And then, as been said by experts in various meetings, you have to move in a stepwise fashion. That is, start with easier cases, then progress to major liver resections, and then you go to major donor hepatectomies. What are the indications? Again, for benign lesions, you have to resect when they are symptomatic or run the risk of rupture, or when you cannot rule out malignancy. The most important malignant lesions that have been successfully dealt laparoscopically at most of these centers doing laparoscopic liver surgery or transplant are the colorectal and other liver mets, mainly colorectal, and smaller HCCs. As I said, anteriorly located lesions are preferred because they are easier. And underlying cirrhosis is not a contraindication, though in the early part of the experience, you should avoid approaching a cirrhotic liver because it runs a risk of extreme amount of bleeding. So you should start with tumors in normal livers or relatively normal livers, and then gradually proceed to resection of the cirrhotic livers laparoscopically. Previous abdominal surgery may make your surgery difficult, but it's not a contraindication, and so is a previous liver resection. It has been shown that you can re-resect a liver laparoscopically safely. And a very important point is, very often your anesthetist will say, oh, your patient is elderly, please don't do it laparoscopically, but this is not true. There are multiple studies, I'm not quoting them here, which have established, and even in the consensus meetings it has been established, that is safe in elderly and obese. So now coming straight away to the outcomes of laparoscopic liver resection vis-a-vis the open surgery, I would be coming to our technique later in the last, is as with the usual benefits that have been quoted for almost all abdominal surgeries that have been done laparoscopically, is that you avoid the scar leading to better cosmesis. Decreased postoperative pain has been cited in multiple studies, though in our own experience, although our experience is shorter, we have not observed any major difference in the postoperative pain. Probably we are taking a longer time as of now. And then decreased postoperative morbidity, which is mainly related to the abdominal wall morbidity, and that leads to shorter hospital stay. And then there is a study actually which says that the cost of treatment comes down because of the shorter stay. But most of these studies have come from the West, where the cost of stay is extremely high. But at least the studies have shown that the costs are not increased if you see it in totality. And when you talk about laparoscopic liver surgery specifically, what are the advantages of laparoscopic approach are that it leads to it has been associated with reduced blood loss and transfusion rates. And when we talk about resection in cirrhotic livers, there are some studies, although they have been debated, that the laparoscopic approach in cirrhotic livers leads to less incidence of ascites and some reduced incidence of post-resection liver failure, because the inflammation associated with the abdominal wall incision is less, the release of cytokines is less, and that may lead to a reduced incidence of post-operative liver failure. And when we talk about the long-term outcomes for malignancy, so it's been clearly shown in numerous studies that it has similar overall survivals, margin negativity, and disease-free survival. And when we talk about malignancy, again, I reiterate, it is about colorectal liver mets and HCCs, relatively small HCCs. And these are some of the most important studies. There are no RCTs as of now to give you a level 1 evidence, but there are large retrospective studies which are like best second degree evidence that we have. And there are 2 large studies from Japan which are quoted on the left side, and they have shown that compared to OLR, LLR in selected patients with HCCs showed similar long-term outcomes and are associated with less blood loss, shorter hospital stay, and fewer post-operative complications. Then there is a similar study from Southampton, UK, which compared the outcomes of laparoscopic resection of colorectal liver mets and compared it to open, nearly 300 cases. And again, they came to the same conclusions, that is similar long-term outcomes and improved short-term outcomes. And then there is a study from Korea where they compared resection in cirrhotic livers, open versus lap, nearly 150 cases in each arm. And again, they concluded that it is no less safe. I'm just reading out, it's not less safe than the traditional open approach. And the oncological outcomes of HCCs were also comparable between the two groups. So in properly selected cases, laparoscopic resection for HCC in cirrhotics is as safe and as good as with open surgery. So these are some of there are many more studies, but these are some of the major ones. And then there is a large meta-analysis that was published about 4 years back. So this figure of 9,000 must have grown exponentially by now, but they collected about 83 studies and from all around the world and did a meta-analysis. And this meta-analysis has been performed by some of the known giants of laparoscopic liver surgeries. And I think that is an authentic study where they've compared the outcomes between laparoscopic and open surgeries. And so as far as mortality was considered, it's equivalent between the two groups. Complications, again, most studies say they are similar, but there are some studies which favor laparoscopic. Blood loss is less. Transfusion requirement is either same or less. Operative time is again same. Hospital stay is definitely less. And resection margin, again, you can achieve the same R0 resections with laparoscopic approach as with open approach. And this is just to the actual figures of what this previous slide was showing, that there's reduced blood loss, reduced transfusion requirements. When you talk about the laparoscopic approach, hospital stay is lesser and operative time is same. So in a nutshell, I would like to say here from till this part of my presentation that laparoscopic liver surgery is feasible both for minor resections, for major resections, but it's a stepwise learning approach. The learning curve is long. So you proceed from minor to major liver resections. And there are certain advantages in terms of decreased blood transfusions, decreased blood loss, and that converts to lesser post-operative morbidity and lesser hospital stay when we talk about the laparoscopic approach. So why does the LLR approach score over the open resections? It's for two reasons. It's the most important one in my view is the magnification. The vision on laparoscopic is wonderful. You can see all the structures very clearly. And this improved vision allows you to see the vessels, take control of the vessels, and that leads to reduced blood loss. Then, as we all know, that pneumoperitoneum is associated with lesser blood loss. And what has been said and has been accepted in the consensus meeting, the Morioka Japan meeting, is that caudal approach gives you a better visualization of the vascular structures. When you are dissecting near the IVC, taking control of the inferior hepatic veins, then even during parenchymal transection, when you use the laparoscopic approach, you can see the undersurface of major segmental veins where in the open approach, you tend to injure the posterior wall while looping. So this can be avoided and is avoided in the laparoscopic approach. And then the visualization of hilar structures is also better. And then an added advantage is that CO2 protects against major air embolism. It's been, animal studies have shown that CO2 embolism keeps on occurring, but they are inconsequential. They have no clinical significance. Because if it's an air embolism, it would lead to major adverse clinical consequences. So this is another added advantage of the laparoscopic approach. But there are certain drawbacks. Nothing is white or black, it's always gray. So what are the drawbacks of laparoscopic liver surgery? One is a very long learning curve. It's not an easy technique. And what has been classically described by the experts is that there are 3 phases of learning. So first phase consists of around 45 to 60 cases, and it's recommended that you should do the relatively easier cases. Don't touch cirrhotic livers in your initial part of experience. Don't go for posterior or superiorly situated tumors. Then the next phase consists of about, when you are doing after the 60 cases, next 30 to 35 cases, your complications come down, your confidence increases, and you can do major hepatectomies. And then the last phase is about another 70 to 90 cases, after which you can call yourself a proficient laparoscopic surgeon. Then the initial costs of setting up a laparoscopic liver surgery unit are like, the costs are quite high. The equipment is quite expensive, and that we have seen in our case also. And the most important point is bleeding still remains the Achilles heel, particularly when you are in the early phase, and it often forces you to convert, because bleeding is the nemesis. It spoils your vision, and you, like in the open, you can just put your hand or compress the liver. It's not so easy to put that pressure, apply pressure and stop the bleeding in the laparoscopic approach. Although I would discuss it later, that Pringle is very useful and it's being increasingly used. Dr. Gupta also mentioned about that in the laparoscopic liver approach. And then posterior superior segments are difficult to access laparoscopically, although robotically it is said that that is the advantage of robotic over laparoscopic. So talking about laparoscopic living donor hepatectomy, it's still not a standard practice, although it has been introduced by the Korean surgeons and has gained broad acceptance in Korea. Again, there's a long learning curve, and the ideally suited would be high volume LDLT and HPB centers doing laparoscopic surgery who should attempt doing a laparoscopic living donor hepatectomy. And then you have to always talk about the recipient outcomes when you are talking about a laparoscopic donor hepatectomy, because there are certain issues associated with, especially when you are taking a modified right lobe and reconstruction of the anterior sector drainage, which may lead to inferior recipient outcomes, although the Koreans claim that there is no difference in outcomes, recipient outcomes, when you compare laparoscopic donor hepatectomy with open donor hepatectomy. So this is again a consistent statement regarding living donor hepatectomy. It was published about 3 years ago, and most of the experts who were on this panel. So what they said is that, again, I'm repeating the same thing, that laparoscopic donor hepatectomy should be attempted in high volume laparoscopic liver surgery centers or LDLT centers. There can be a gradual transition from a laparoscopic assisted approach to a pure laparoscopic approach, but that depends on your philosophy. And laparoscopic left lateral segmentectomy can be considered a standard approach, although again, it's not accepted by everybody for pediatric transplants. But laparoscopic donor hepatectomy is still a technique which is still developing and should be performed only again in centers with a lot of experience. So this is what the consensus says. And then this is a study, multi-center study from Korea, where they showed very good results of laparoscopic, pure laparoscopic living donor hepatectomy. And it's an experience of around 550 cases where the conversion rates were only 1.8%. Those are excellent results. And note the complication, major complications, that is Clavin Endo grade 3 or more, there were no mortalities and was only 4.6%. So these results, I think they are a benchmark. They are a kind of gold standard which have to be replicated by other centers before it can be recommended that you can do a pure laparoscopic right donor freely and by all LDLT centers. So since I've been talking about bleeding, and as I'm repeatedly saying, it is the killer of laparoscopic liver surgery. So what are the maneuvers for control of bleeding? I would say they are more or less same as you do in open surgery, but with the advent of laparoscopic liver resection, Pringle maneuver has again come into vogue, and laparoscopic Pringle has been described in detail in numerous papers. Then other measures are, as we all know, increasing the pneumoperitoneum, lowering the CVP, and then lowering the airway pressure. You ask your anesthetist to lower the airway pressure briefly, or even disconnect the ventilator for 15-20 seconds, and that has a dramatic effect on the bleeding. But the age-old technique of applying pressure, and in this case you use small gauze pledgets and press them with your suction device or any other laparoscopic grasper and just wait patiently, I think that works wonders. That is what I've seen. Magnification definitely makes a lot of difference. And since in suturing on thin-walled bleeding vessels, most of these bleeds are from the hepatic veins. Portal vein bleeds are much less common, so they don't take sutures that well. They tend to cut through, especially when you have a bloody field, can't see much. You may end up damaging these veins, narrowing these veins, or may worsen the bleeding. So it's better to apply the clips reduce the bleed, and then take the suture when the field is clear. And of course, nothing can beat a trained assistant. You cannot do a laparoscopic liver surgery, especially in a bleeding liver, without a trained assistant holding the suction and clearing the field for you. So that is of utmost importance. I cannot overemphasize on that point. Just a slide about parenchymal transaction devices. So as Dr. Gupta said that there are so many devices, we have experience of most of these devices, and it's a personal choice. Almost all the consensus meetings have come to this consensus that it's your personal choice. No particular device is superior over the other. So I've highlighted the ones which we use frequently, that is the CUSA, and I'll vouch for CUSA XL because it has a cautery along with it. Then ultrasonic shears harmonic, again we use, it's a kind of hybrid technique that we use, that the initial part of the transaction is with a harmonic because it's faster, it's easier, and then when you come into the deeper parts of the liver and when you need to see the bigger segmental veins precisely, you shift to CUSA. Bipolar is very helpful. You can use keep the bipolar in the left hand, as most laparoscopic surgeons would do, and then clips. These are hemlock clips and the regular Liga clips that we use. Underbeat is used a lot by the Koreans. Then Lotus, Dr. Chris Menon from UK, he uses the Lotus, but these are different energy devices with their, and it's only the surgeon's choice and comfort. No one technique is better than the other. And Hydrojet we used to use previously, but because of the expenditure, we have stopped using it, though it's again a good transaction device. So sharing our nascent experience with laparoscopic liver resection, we have done in the last 1 year 44 cases. Majority are females, and that there's a reason for that, because Paris females are the best suited patients for laparoscopic liver surgery in the early part of your experience, because you can have a very good roomy abdomen. When you create the new peritoneum, you get a lot of space to operate, and liver is situated high up underneath the costal margins, so space is of paramount importance. In our own experience, we have seen that when you can create a pneumoperitoneum in a muscular young male, there's hardly any space to turn the liver around. And most of these patients are middle-aged patients. 2 left lateral segmentectomies for tumors, 1 isolated segment 6 resection again for tumors. Then major part of our experience consists of living donor hepatectomies, that is 41 cases, of which left lateral were in 8, of which we could complete 5. Modified right lobe is definitely more difficult, but since most of the transplant recipients would require a right lobe, so we have embarked on the right lobe, and we have been able to complete 11 out of 33 till now. Average blood loss has been about 2.5 units, though it is cumulative loss, and the blood loss is gradually coming down as within increasing experience. And what the Koreans in their living donor experience have reported a blood loss, about average blood loss of around 1.5 units. So we are 1 unit ahead of higher than them, and we expect to come down with increasing experience. So is for the operating time. It's for a living. This is about the right donor hepatectomies. It varies from 9 to 10 hours. In the Korean study, it was about 6 hours. So, but that is after a 10 years experience. So I think we'll be reaching that mark soon. The reasons for conversion in the 25 patients that we have done, bleeding was the main cause in 7. And the sites were inferior hepatic vein clip slippage in 2, which soiled the field completely. Portal vein is easier to handle, that is what we feel. And that bleed was in the very initial case where there was a bleed from the portal vein and we couldn't control it and had to convert. In one recent case, we had a tear in the right hepatic vein, and that was really kind of catastrophic, but we converted immediately, and the patient recovered without any problems. And most of the remaining bleeds were during the transaction. They are segmental bleeds. The bleeding is not that great in amount, but controlling them is more difficult because these veins are very thin-walled and they are encased by the liver parenchyma on all sides. But with increasing experience, we are gaining more experience, confidence about controlling bleed from the transaction, during transaction. And while most 18 conversions were planned conversions, like we started with, we would do this much in this particular case, and that is how we progress. So First few cases were just about liver mobilization, then next about doing the porta, then next doing the transaction. So the 18 conversions were just part of the learning curve. And there were no definite catastrophe or injury which led to forced. These were not forced conversions, were planned conversions. So before I go to the video, I would just point out the salient features of the technique we use. It's basically a replication of open liver resection or open donor hepatectomy. We use the French position as most surgeons do with the reverse Trendelenburg position. We use 5 ports. 3D endoflex vision, that is the Olympus equipment that we use, is really remarkable. It's amazing vision that we get through it. Operating ports are placed high up, close to the costal margin, because as you proceed with the resection in the superior segments, your instruments tend to fall short. So the port should be placed as high as possible. We do early hanging because we are still on the, we have not completed our learning curve, although many experienced surgeons say that you don't need to hang the liver, but early hanging helps. It helps. It's a kind of guide. It's your pole star, which helps you deviating from your transaction plane. After our initial bleeds from the IHV, we have started using hemlock clips for the larger IHVs, and that has really made a difference, because when you're trying to tunnel, the liger clips tend to slip. Early marking of the ductal bifurcation again helps us, especially during donor hepatectomy, from venturing or deviating towards the left side. And since we are not doing the cholangiography, the routine cholangiography, so as all the surgeons do, we also use the ICG fluoroscopy for the demarcation of the transaction plane. We use CUSA XL as along with harmonic as our energy transaction and energy device. And the most easiest thing and the most effective thing for control of bleeding, especially during transaction, is use of gauze pledgets, followed by clips for control of bleeding. In ductal division, we do as we do in open, that is after looping the hilar plate, and the ductal stump is secured with hemlock clips. So these are some of the salient features. And this is a video of a laparoscopic right lobe donor hepatectomy. So we use the standard 5 ports. Falciform has to be divided high up, otherwise it hangs and obstructs your vision. Then this is creating a groove between the right and the middle hepatic vein. So that helps in tunneling. Then we move to the inferior surface of the liver, and this is mobilization of the right lobe, dividing the right triangular. This is the mobilization of IVC by dividing the inferior hepatic veins, and we use clips as hemolocks. Hemolocks for the larger ones, clips for the smaller ones. So this is the early hang after tunneling of the IVC. So now we can see a tunnel has almost been created, and this is the gold finger that has been inserted to further complete the tunnel. And now we are inserting a Riles tube from the under surface of the liver, and that has appeared from the superior surface in the groove that we created between the right. And this is the portal vein which is being dissecated and looped. So division of the caudate branch of portal vein is very important, otherwise you can have bleed, and you can see a small clip there which has been applied before you can loop the portal vein, and this is not a very difficult maneuver. Next we come to the hepatic artery, and we don't use energy devices here. We are just using a Maryland to dissect out the artery, and here you can see the artery pulsating. And then we are doing the cholecystectomy, although we have started doing cholecystectomy first, as all other surgeons are doing. Initially we were not doing it because the conversion rates were high. So now this is the division of this, and this is the application of the bulldog laparoscopic, and you can clearly see the demarcation plane. So this is an ischemic line, and this is the after injecting the ICG, you can clearly see the demarcated line. This is the placement of stay sutures, and then we apply the traction. We use this slings for traction, and that helps, reduces the work of the assistants a lot and helps in stabilizing the transaction. And this is the transaction using the CUSA XL, which has an inbuilt diathermy. And this is the segment 5 vein that is being clipped with a hemolock after proper dissection all around. And there's a great advantage laparoscopically because you can see all around the vein. So this is the division after double clipping. Then we proceed further and encounter the segment 8 veins, which are again clipped and divided. There were 2 veins. One has already been divided with hemlocks, and this is the smaller one. Then we come back to the porta, and this is looping of the bile duct. This is very similar to the one in the open. So the vascular structures are separate. Again, use the ICG to delineate the right versus the left. Here we can see better, right and left. And once you're sure, then you loop it, apply a hemlock and clip it, and divide it, sorry. And so this is the division of we divide more to the right and what, and then the right has been brought up to complete the transaction of the caudate part of the liver. This is the transaction. Now this is edited plot on the canvas. I'm sorry for that vision. And now we use a stapler for dividing the portal vein. We have used both clips and staplers depending on the size of the portal vein, and here the inflow has been totally divided. Now we can visualize, see the right hepatic vein nicely, and the stapler is being passed across, stapler applied, and the graft is collected in a bag, endo bag, and then you can remove it. And this, in this particular case, we removed it through a pen and steel incision. So that is a brief video, although this was a much longer video, but has been edited to about 10-11 minutes in the interest of time. So sorry.
Right. Thank you very much, Dr. Agarwal. It's a lovely presentation.
So I still have 2 more slides.
Yeah, sure. Please carry on.
Like, position of is important. It can be the very, they cannot, like in a plate.
The voice is interrupting. Sunil.
For me as well, for me as well. Can't hear Dr. Shalin.
We can't hear.
Dr. Shalin stuck. I think Dr. Shalin stuck. He'll probably try to get back in again.
Right. Now, in the meantime, I think, Ramdeep, if you have any queries, you can.
Not queries since Dr. Shalin is off right now, but
I can answer on his behalf.
Yeah.
I can answer on his behalf.
One question is, can I ask something?
Yeah, sure.
Do you use a hand port? Do you use a hand port for?
I think the hybrid techniques are to be condemned. Either you do fully laparoscopic. Hybrid is the worst of both the worlds.
No, but I was thinking for a beginner, will a hand port help?
Shalin did mention that. Shalin did mention that when it's in a learning curve, they used to do it.
No. That is different.
Yeah.
What we are doing is what we're doing is slightly different. I think Dr. Shalin has come back online. What we're doing is that we complete the transaction, we divide everything, but we take because right lobe of the liver is very big.
So to answer your question, we haven't felt that you really need to do a hybrid technique, especially after a lot of experience with the open liver surgery. I think that hybrid technique, although there is no criticism of that, comfortable with that transition from open to pure lap, that has been accepted. There's hardly any space left when you have a large liver in the right fossa to manipulate your hand and do it. It makes it very messy. That is what I've seen. We have not done. So we have not felt the need for it actually.
Right.
So what let me elaborate that a bit further. What we are doing, because the right lobe needs to come out from a big incision. So sometimes once you've done your transection and you've looped everything, and so whether you take it out from Fanon style incision or you take out from a small midline incision, I don't know. Small midline incision gives you much better control, and I think it may perhaps be the way forward in the future, at least for living donor hepatectomies, because
Yeah,
there's so
that
much more
makes it very
precision, and
safe actually.
uh, when Professor Su came to our center to demonstrate this, he also had terrible bleeding from the cava when he was trying to take the liver out, and he's done a huge number. So I don't know. So many of our sort of midline incisions are, it's rather Fanon style incision may put in the midline rather than, a true conversion.
Right.
Can I ask another controversial question? What
Yes,
is your
Yes,
opinion
sir.
regarding GBCA LLR,
Sorry, sir.
gallbladder carcinoma?
Well, yes, there are publications, and some of our colleagues are doing that. Till now, there is no consensus on that, but whatever the series have been published from individual centers, they have shown equivalent results. Long-term oncologic outcomes are still awaited, but in the short term, they have said that it is no inferior to the open technique, and the usual advantages of laparoscopic surgery, which are purported in almost for all laparoscopic procedures, are there. That is cosmesis, less pain, and early discharge. We are yet to see the long-term outcomes.
Dr. Shalin, excellent presentation and very impressive because right lobe laparoscopic liver resections can be very, very challenging and daunting. Would you attempt on hilar cholangioCAs as well?
See, hilar cholangio is a totally different ball game. It's a surgery where it is the R0 resection which is most important and not the approach. An incision is not going to a person for whom R0 resection is the mainstay of whether he lives or doesn't live. An incision is not important in that condition. And in hilar cholangios, palpation plays a very important role. So I would, till now, well, things may change in the future because so many of our theories have been turned on their head as the years pass. But till now, I would feel hilar cholangios should be done open. This is a surgery which needs lots and lots of precision.
True.
Multiple frozens are needed. So I would not venture laparoscopically for a hilar cholangio, because many of them are actually, you don't know whether you'll be able to resect them or not. Even with the best of imaging, you can only have a fairly rough or an estimate of whether you'll be able to resect, but final court of appeal is intraoperative only.
Well, thank you very much, Dr. Agarwal. Yes.
Thank you, sir. Thank you for that.
Any further questions?
No. Thank you. Excellent.
I think Dr. Subhash wanted to emphasize some points regarding the access, the incision. Obviously, he mentioned that preferably maybe midline would be preferred than Fanenstein.
No. The number of reasons for that. One is that, we've done 3,000 living donor liver transplant. We've not encountered a single case of adhesive intestinal obstruction.
Right.
Many of our donors are young females who want to get pregnant later on. So I don't know whether we should be doing a Fanon style incision, a small midline incision, and take the liver out. So I think that is open to debate. I mean, right now, in a male, it makes sense, I suppose, or somebody. But speaking to David Kwan, who's a good friend, and he's saying that if the liver, if you have a big liver tumor, there's no point doing it laparoscopically because you have to take it out through big incision in any case. So, you can. It's not like a uterus. You can do a morcellator and put it in a bag and take it out. You cannot. It's not. So right now, I think it may be better you do everything laparoscopically, but you actually take the liver out. You make a small midline incision, get good exposure. You divide everything under vision and take it out, rather than clamp slipping or a stapler. But that is what. As I said, Shalin and me discuss this often, but first we must do it the way it has been done before we start condemning it. Otherwise, people will tell us that, you don't know how to do it.
Actually, I have not.
Anyway, that's an excellent presentation. I think everybody had enjoyed. We are running short of time, We would have to get the sponsor to talk about their staplers for a minute. So if you, Sunil, if you could allow him to enter. Is Sunil with us? Right. Can you allow the Johnson Ethicon people to talk for a few minutes before the meeting gets over? I think Johnson, they are going to speak about the new circular staplers, although it's not applicable for the liver resection. But I think this is.
Hello.
Yes.
Hi. Sorry. Hello. I'm Devjani from Johnson & Johnson, and I'll be speaking on behalf of my colleague. If I could just share my screen, please.
Yes, you're seen. We could see you.
All right.
But the screen, no. We can't see your screen.
All right. So I'll just try. Yes, I'll just try sharing my screen, and if you can just let me know if you're able to see it.
Not yet.
Not yet.
Right. So is this visible?
Yeah, we can see you now.
Yeah.
See the screen now.
All right. So great. So I'm not going to take too much of time. And honestly, this was supposed to be my colleague, Dr. Vineet Agarwal, who was supposed to take the session, who's a surgeon and also the professional education manager for J&J. Unfortunately, he had logged in but had to drop off due to an emergency. So I will be filling in for him. I'm Devjani Ghosh from the marketing team at Ethicon India. And I lead our charter for oncology and all our devices that get used in staplers and energy devices used in open surgery. So I'm going to try to do my best in a very august company like this. So do give me that little margin of error in case for anything during this presentation. So what we'd really like to speak to you today about is our new powered circular stapler and the role that it can play in standardization of outcomes in surgery. Right. So our common goal with all of our customers really at Johnson & Johnson is to have optimal patient outcomes. So we try our best to understand the device to tissue interaction. We design our staplers for better outcomes and then validate with evidence. And we keep repeating this circle so as to be able to get better and better products out in the market. One of the common and the most dominant concerns that for most GI surgeons that are there, of course, is anastomotic leakage. And we all know that this is a serious, important complication. So I understand that this session is, of course, has been primarily focused on liver, but nonetheless, everybody does also have a good GI practice. And therefore, we thought it would be good to talk about our circular staplers and anastomotic leakage. So, of course, anastomotic leakage is not dependent on a single factor. It's multifactorial with many different variables and many different factors having their own role in it. It could be because of patient factors such as disease and comorbidities, history and the physical condition of the patient, and also the patient's own compliance with care. It could be because of factors such as the device tissue interaction or the device and user interaction. It could be because of factors just related to the facility where the operation is taking place, or it could just be surgical techniques, right? So nonetheless, all of this, of course, in order to ensure that we have a more predictable outcome, a lot of work does revolve around standardization. Right, so whether it's standardization of indications in order to understand which patients we should be taking in, say, for example, for a minimal access surgery, and which patients to avoid and so on, whether it's standardization of the surgical technique, be it a minimal invasive or be it robotic. Right? At the end of the day, most of senior surgeons like yourselves who are leading departments would like to standardize techniques within your own departments in order to have predictable outcomes. If you look at specifically within colorectal surgery and GI surgery, I think one of the initial journeys of standardization of technique was really started by Professor Bill Heald with TME for LAR. So therefore, the standardization of technique in terms of the dissection, the standardization of technique in terms of reconstruction, in understanding how do you assess the tissue in terms of assessment of perfusion, especially more so with techniques such as devices or technologies such as ICG coming in assessing the tension at the anastomotic site, and of course then comes the technique of just doing the stapled anastomosis in itself. So if you talk about the technique or the standardization of just the staple technique, so there's something which the device gets in terms of some of the proprietary technology that we bring in, right? Powered firing is of course common, but gripping surface technology and 3D staples is proprietary Ethicon technology that comes in into our staplers to give a more predictable outcome. There's technique which the user basically follows in terms of while using the stapler, like the 15 seconds pre-compression or the assessment of donuts. And of course, this technique that we follow as device manufacturers in terms of testing the devices as well. So all of these factors basically contribute in order to get us a more predictable outcome when you do fire that stapler. So I'll talk about the first three pieces, which are directly pertaining to the powered circular stapler. So the powered circular stapler, other than being powered, also basically comes in with two other technologies. One is called the gripping surface technology, which is designed to give precise compression just where the staples are being formed. So what do I mean by this? So when the staple pins pop out of the stapler and they curve in, the curved edges are the ones which basically hold on, are the ones which have to resist the maximum forces from within the tissue. And therefore, we ensure that with certain changes in the design of our stapler, we ensure that there's more precise compression or compression given exactly at those points where the staplers are caving in, which ensures that they are actually held more tighter. Second, this is a 3D stapling technology, which many of you may have used in our open linear cutters. We have now brought this into our circular stapler as well. The 3D staple technology is slightly different from the traditional V-shaped. So this ensures that we cover a much larger surface area of the tissue, even with a two-row staple. So basically, between the GST technology and the 3D stapling technology, what we ensure is that we give the adequate compression and also adequate surface area of the tissue is covered with staples, and at the same time ensuring that there's enough pathway for the blood to flow and the anastomosis to heal. The last bit, and I think which plays the most important role in standardization, is really the powered firing. I will just show a short video which will help you to really appreciate the difference in the stapler movement when it comes to powered versus a manual firing.
No audio?
So let me just try sharing once again then.
The Echelon Circular Powered Stapler delivers increased stability with a powered firing platform. A preclinical study was conducted between the manual stapler and the Ethicon Echelon Circular Powered Stapler. The study tracked the movement at the distal tip of the devices during firing. You can see that the Echelon Circular Powered Stapler has significantly less movement at the distal tip during firing, which may lead to less risk of tissue trauma on the newly formed anastomosis.
I'll just pause the video here. So if you can see especially for those who would have fired the manual circular stapler, we do realize the amount of pressure that needs to be put in, especially while for a rectal anastomosis, and the amount of movement that might happen while you're actually putting in all that pressure and body into firing the stapler. And with the powered stapler, of course, there's no movement that comes in. It's really literally just the push of the button. And that is what ensures that there is, especially for those ultra low cases, there's really no movement of the stapler while firing it. And then finally, I'll just come back to my concluding slide. So finally, so we did talk about, so in the opening slide, we did talk about the evidence that we also try to generate around our staplers. While powered circular staplers are still fairly new, they've been around for just over a year. We did have a recent study coming in from Spain, which was a cohort study that looked at anastomotic leak rates and compared the ones with manual versus powered. While of course with manual in their particular practice, they had about 11.8% leaks, anastomotic leaks with the manual circular stapler. With the powered, they found it to be at about 1.7%. Of course, this kind of data is varying from practice to practice, but nonetheless, the point being that a powered circular stapler could possibly play a role in reducing complications within the surgery. And the final few takeaways. For a good anastomosis, healing, of course, capturing all layers of the tissue is important. Appropriate compression where desired in a circular stapler gives the better anastomosis outcomes. We do extensive burst pressure testing on our circular staplers, and this revealed that the 3D GST 2-row stapler did provide better tolerance than any other devices. And finally, all of this put together really helps in standardization of the anastomosis technique, especially for stapled anastomosis. So that's about it from me in a quick nutshell about the new circular staplers. I'm happy to take any questions on the product if there are.
Well, thank you very much, Debjani, for highlighting the new powered circular stapler. I think we have used in our center at AMRI. Now, the liver surgeons might be getting bored with your circular stapler, but
Sure.
I think I wonder whether you have that sort of any powered stapler for the vascular linear stapler. You don't need that, do you?
We have the vascular stapler for on the hepatic veins.
Yes, yes.
That's right.
Yeah, that's also a powered stapler.
That's right. Yes, sir.
Right.
Thank you, Dr. Gupta and
Yes.
Dr. Agarwal. We
Yeah.
have the powered vascular stapler. We call it the PVS stapler, which is available
Yeah.
for.
Yes.
But what we don't have is those which fire staples on only one side.
Yes, we don't have it. It will be on both sides with the knife in between. That's right, sir.
So we need one.
No.
Because, you know, when the Koreans came, they had this stapler which only fired on the one side, so that you don't lose stump of the vessel for anastomosis.
Understand,
Yes,
sir.
for the recipient.
Right,
You mean
sir.
yes?
No, so we don't have that in India as of now, but hopefully soon enough.
There'll be a lot of demand for it. We ourselves will use 300 of those every year.
So I'll certainly take that back to my managers when we're deciding on products to get in. Right.
And same
Right,
also
thank you.
multi-fire clips.
Sorry, sir?
The multi-fire clips, only one size is available. While the Koreans, when they came, they had all the sizes.
So you mean
from
for the
100,
lab?
200, 300. But
Okay.
here we have only like 300, which are sometimes too big and not very useful.
So you mean for laparoscopic surgery or for open?
Laparoscope.
For laparoscopic surgery, right? Right. Yes, so we have only 300 and 400 at the moment and EL5 ml, yes, sir. So again, thank you for it's always good to get some feedback coming in from some of our very key customers from across the country. So definitely we'll take that in. And I do hope you also found the session, the little short talk on the circular stapler also a little beneficial.
Thank you very much.
Thank you,
very
sir.
much. Yeah. Thank you very much, everybody. Subhash, Dr. Agarwal, Ramdeep, and Dr. Banerjee. Thank you so much.
Thank you very much. Thank you. Have a nice
for your
meeting.
participation.
Dev and Ramdeep and everybody.
Thank you, sir.
Thank you.
Bye from Calcutta.
Bye.
Bye.
Thank you.
Good night.
Good night. Okay, Sunil, we leave. Sunil, are you with? Yeah, we leave now. We end the session here. Okay, bye. Thank you so much.